colleagues. I'm Laura Hobson. I'm a professor of emergency medicine at the University of Michigan in the United States. This is going to be the first of 5 sessions. We created this collaboratively with the idea of really hoping to inspire people to learn, as well as to create collaborations across an ocean and relationships that may help build a vision for what a medical education may be. During the next 2 hours, we are going to hear from Dr. Lawson, the Vice Rector of the Ghana College of Physicians and Surgeons, who I think is all very well known and esteemed by you. We will have 2 focus talks, the first on bedside teaching models involving Dr. Carolyn Komisaris, who is a former trainee of mine and a wonderful educator and is currently at Harvard Medical School in Boston, as well as Dr. Judah Nan from Kumasi. And the second lecture also involved Dr. Komisaris and Dr. Kwao on slide design for the didactic learning environment. In the meantime, I'm going to hand you over to the Vice Rector for his opening words.
Thank you very much. I'd like to share my screen. If it's all right. Good afternoon, everybody. Thank you for making the time to come. Thank you, Laura, for this collaboration and all the work you've done. The truth of the matter is we wanted to do this sometime last year. We set off, we got a hitch, then we rescheduled, and finally we've been able to do this at this time. We also initially advertised 6 sessions, but we repackaged it to have 5 sessions, and I assure you will have quite a good time. So this is basically just an introduction to the medical education seminar series. As she said earlier, we are collaborating with the University of Michigan Medical School to get this program going. So I will talk briefly about, give an introduction why the college is doing this, compare us to other colleges, what we have done in the college in the past, and what we want to do in the future. So we generally at the college, we expect that all specialists and senior specialists must be involved in training. We expect that you are imparting skills, knowledge, and competencies to our residents to perform certain tasks. Basically, most of our training is practical and it's hands-on. And we expect that we need to focus on acquiring specific skills. And then key on it is be able to give feedback to our residents as to how they are doing in a timeous manner. So why is the college embarking on a medical education series? It's not that we have not done anything like that before, but our key objective is to improve teaching and training skills. We think our trainers should be evidence-based in their practice as to what they do and how they do things. We also want to open the door for research in medical education. We do a lot of clinical research, which is quite good, but the exam processes, assessment processes, and things that we do, our training models and methods, we don't do a lot of research in that area. The few that have ventured into to do a master's in medical education may have done research in that area. But with this, we want to open the door for more of our fellows to do research in this area. We also want you to stay current in medical education, know the latest trends and the best practices. And then also for some of us, this will help us in our career advancement because we are looking at a career in medical education, curriculum development, simulation, and then educational technology. So what have we seen others do? The Royal College of Physicians of London collaborated with the West African College, I think in 2011, and began a program called the Doctors as Education Program. A few of the senior fellows within the West Africa space and the Ghana College space have attended this program. And it covered topics like adult learning, curriculum development, teaching methodologies, and the like. It also covered medical education, research methods, managing learners with difficulties, supervision, mentoring, and other topics. For those who were interested, more interested, some have ventured to do formal training programs as doctors. So there's a postgraduate certificate program that is available. It's a 60-credit course in most universities in the UK and the US. There's a postgraduate diploma. I think about 3 or 4 universities in Ghana are offering the postgraduate diploma, 120 credits. And then some have gone further to do an MSc or a Master's in Medical Education or a Master's in Health Professionals Education, which is 180 credits. 60 credits of that is coming from a project that you would do. The thing is that a lot of doctors have approached the college, they are interested in doing these things, but the biggest challenge is the financial burden. The tuition fees, for example, in the UK is about £17,300 for a part-time full master's program. Now, this translates to about 280,000 Ghana cedis. But that is not even the catch. The catch is that that is for UK citizens. For overseas, it's a £31,000 affair. And for figures like these, without sponsorship, a lot of the doctors who may be interested in medical education training are not able to pursue this. So in the past, the college has tried to bring medical education to the doorstep of our fellows and our members. I can go just 5 years back so that we can look at some of the things we've done. In May 2019, we had a 3-day workshop. Now, all these were before COVID came. So the modus operandi at the time was to do in-person workshops, either residential or non-residential. And so we did this 3-day workshop in Accra. The following year in January, we moved to Kumasi. And some of the things we did at that program were supervision, basically on supervision, supervising postgraduate project work, what a supervisor should do, what the resident should do, challenges in supervision of project work. We also looked at supervising the final project report and then research integrity, looking at plagiarism and other issues. On the second day, we looked at MCQs for assessment. We overviewed the Bloom's taxonomy, how it's related to setting learning objectives and also examinations and assessments. We looked at the structure and design of MCQs. We had practical sessions where we had doctors have practice. Then we had a session on mentoring, which is similar to what we'll be doing very soon. Overview of mentorship, assigning mentors to mentees, the mentoring process, and then challenges in mentorship. Then on the third day, basically hands-on, we worked on selecting research topics and titles, helping a resident to write a literature review, helping a resident to write a research proposal, and then how to mark fellowship dissertation. So this was run for Accra and Kumasi way back. And then the following year, we actually did a program with the University of Cape Coast, and we got some education experts who came and worked with us on a further MCQ setting. Then 2022, we shifted to research methods. We had a 2-week program, but at that time, COVID had stepped in. And so we did this format where every evening we would have a session for a 2-week period. So we did an introduction, we did a lesson on choosing a research topic, we did developing a research question, performing a literature search. We also, in the second week, we did research designs, basic statistical analysis, components of a dissertation, and then using reference management software. And the good news is all these programs were recorded and the videos are freely available on the college website. If you open the college website, just scroll to the bottom, you'll see a knob called training videos. And the first one you'll see is the components of a dissertation. But when you go to the bottom of it, there's a little icon there. When you click on it, it will reveal all the other videos. They are on YouTube, recorded on YouTube. You can watch for free. You can save it and then keep going back at it. So that's what we've done in the past. For now, this is the program that is designed. We have 5 sessions. We are trying to do 1 day per session in the evenings. The timings are a little different. Some may be 2.5 hours, some may be 3 hours, but only for you to note that session 4, which is highlighted in red, it's a Thursday evening, not a Tuesday evening. All the other days are Tuesday evenings, but session 4 is a Thursday evening. So kindly take note of that. And then so today, Laura has shown us what's going to be done for today. I just want to remind you also that the mentorship training is being rehashed. We did it in 2019 and 2020. We are going back to it. So this will be advertised from tomorrow. You see it on our platforms so that you register, and we start on the 4th of April. This time we have a session for residents and another session for trainers. Each session is the same. So if you attend as a resident, you attend 4th April, you don't have to attend 25th April. The content will be the same. And for the trainers, what we do on 11th April will be the same thing we'll do on 2nd May. We are doing it twice to increase the opportunity for everybody to have a taste of it. So finally, what does the future hold? The college would like to use this platform to reach out to doctors who, privately, you may have done a program in medical education. You are keeping the certificate to yourself. We want you to approach us. We are trying to put a team together to look at how we can advance medical education within the college and even outside the college. We also want to encourage more doctors who are considering postgraduate training in medical education and may not be sure of what to do. You can approach us. Some of the fellows who will be giving the lectures have done the masters in medical education, and they can give you guidance as to how to go about it. And then also we are looking at collaborating with other professionals in the health sector, the pharmacists, the nurses, the physiotherapists, to look at starting a health professions education faculty, which will be championed by the Ghana College. Then also we want to expand our collaborations. We already are collaborating with the University of Michigan. I know the Faculty of Family Medicine is also talking to the American Academy of Family Physicians, and they are looking at helping fellows in family medicine train in medical education. So these are areas that the college is beginning to look at so that we have a more formal and more structured medical education program within the college. So thank you very much for listening. I'll hand you over to Laura to continue the rest of the program.
Thank you. I think for many of us, we can identify some fabulous bedside teachers who really influenced us over the course of our careers, and particularly during our learning years. Our first session is going to be on some techniques that can optimize all of our capabilities and influence at the bedside with our new learners. And I'm going to turn this over to Dr. Komasaris and Dr. Anand. We would encourage you to use the Q&A if you have questions. We will have a 10-minute session at the end of this, in which you can take a quick break, in which you can ask questions. And we'll also have an evaluation form available for you, both with a link both in the QA section as well as visible as a QR code on your screen.
All right. And I see Dr. Anand is connecting to audio now. Let me see if I can get these slides going. All right, so hopefully that looks legible. And so I'm going to just introduce myself briefly while we're waiting for Dr. Anand to connect. So first of all, I want to thank the folks from the Ghana College, Dr. Hobson, Dr. Otang, everyone who put all of this work into this program. That's really exciting. And we are really excited to kind of kick this off with some really bread and butter teaching topics during the session today. So my name's Carrie Komasaris. I am an emergency medicine physician in Boston, Massachusetts, at Harvard Medical School and Brigham and Women's Hospital, where I serve as one of the program directors for our emergency medicine residency. And I think Dr. Anand will be introducing himself and talking about our objectives. Hopefully he's got some connections. Well, what I can do while we're waiting is briefly kind of talk through our objectives for this talk. So we have a couple of things that we're hoping to achieve during this presentation. The first is to reflect on previous experiences that we've all had with bedside teaching as both a learner and a teacher, including some of the strengths and challenges in like reaching that effective teaching goal. Next, we'd like to review adult learning theory as it applies to bedside teaching. And so just talking a little bit about some education theory so that we can use that as our foundation. And then lastly, we're going to go through some really practical pearls and advice for how to approach bedside teaching, despite all of the challenges that can make it difficult. So before jumping into those challenges, I wanted to give folks an opportunity to reflect on their experiences with bedside teaching. Both bedside teaching episodes that have gone really well, and you finished that shift, you finished that rounds or that clinic day, really felt like you made an impact. Those episodes that kind of went, so-so, and those that were a proverbial dumpster fire in that they just were not successful at all. If you can kind of think about that independently, give an example or so in the chat, just so that we can all kind of think back to our own experiences before we jump into this topic. One of the things that I always think about with bedside teaching is how important it is to really adjust the teaching content to what's going on in the clinical environment, whether it's really busy or a little bit slower and you have some more time. And both one of the best and one of the worst bedside teaching episodes I experienced as a resident and as a learner was a 30-minute presentation that one of my faculty members gave me on new onset seizure and how do you approach a patient who has a first-time seizure, what kind of emergency department workup is necessary right then and there, needs to be admitted, who needs follow-up studies. And during a slower shift, when I had just seen a patient with a new onset seizure, it was super effective and super relevant and really interesting. And then when I was given the same lecture during a really busy shift when I hadn't seen anyone with seizures, it was simultaneously really frustrating and less effective. And so it was really important in that circumstance to have kind of customized the content to what's going on and what's relevant to my practice. I don't know if anyone else wants to share any examples of their experiences.
Yeah, I think that experience of customization is a really important one. There's also the experience of of having to teach in a very public environment where you not only have to, I think, respect somebody's feelings of competence, but also a patient or the staff's perception of whether or not somebody is capable, and try to engage on that level as well while protecting someone.
Absolutely. I think one of the hardest things about bedside teaching is that lack of control in the environment. It's really important to keep in mind who is everyone all around us and how we can do a bedside teaching episode that's beneficial to the patient, to the learners, to the person who is giving the presentation or doing the teaching, but still very cognizant of things like some of the social pressures of learning publicly or learning in groups. And also, how can we do bedside teaching in a way that's going to be effective for patients and not either intrusive or uncomfortable? I'm just going to pause one moment to see if we can help Dr. Anand connect to the audio.
So while we are waiting for Dr. Anand to join, what I want to ask about experience is,
Yeah.
the whole bedside environment is opportunistic.
Mm-hmm.
And you may have a specific case in front of you, but there's always opportunity to expand the principles that the student or the learner can apply in other situations that are not exactly the same as you are saying.
Absolutely. So that's actually, I swear it wasn't a plant. That speaks to one of the biggest challenges that we're going to talk about in this talk. And that is this mismatch between patient pathology that you see in the emergency department or see in your clinical environment and what your learners need to know, right? I feel like there are these two Venn diagrams of what's our bread and butter, what's our clinical things. And then, especially in my field of emergency medicine, a lot of the things that we consider core content, really important to our curriculum, are really rare and things that, you may see once a year, once in all of residency, once a career, but you still need to have that knowledge. And so how to incorporate some bedside teaching that addresses those knowledge gaps while recognizing the fact that you may not see that pathology on shift today or next week or ever. And so one of the things that we'll talk about in a little bit is how to apply kind of adjacent teaching to those experiences. And so one of the things I like to do, and I'm just going to jump ahead a little bit, just so I can answer this question most effectively, is talk about how we can address those things. So we have this patient pathology mismatch. And one of the things that I do is called strategic questioning, also kind of known as the game of what if. And so I will use this example to broaden the information that learners can receive by saying, okay, you just saw a very straightforward patient in emergency medicine. You saw a patient with a cellulitis or a soft tissue infection. That's fine. We can talk about the antibiotics. We can talk about the treatment plan for this patient. But let's time out for a really short period of time, right? This isn't something that needs to actually, like grind your clinical shift to a halt. But you take 60 seconds to say, okay, the game of what if. So if this patient has cellulitis today, how do we approach them differently if they come back tomorrow and they have crepitus? And let's spend 30 seconds talking about necrotizing fasciitis. Or what if they have cellulitis, but it's actually starting to encroach into their ear? And actually, maybe it's not cellulitis, it's perichondritis. And we'll talk about infections of the cartilaginous surfaces. What would you do? And I think we do this a lot in Boston because we have lots of resources and specialists and things like that at our disposal, but playing the game of, okay, you would manage this way here in Boston. What if you're in Alaska and there's a snowstorm and there's no helicopters running? Is this a person who needs to be transferred to another hospital for a higher level of care? Or if you did not have a specialty or an admitting doctor in your group, you had to take care of this on your own, how would that change things? And so that strategic questioning can help take a scenario that you might think is not actually that educational and make it much more relevant to your learners. And also that helps us find that zone of proximal development for our learners, because I think a lot of what we see, at least what I experience, is that when I'm working, especially with our senior residents who are really almost ready to graduate, it can be hard to teach them on shift. It seems like they're almost ready, and they are almost ready, which is exciting, but there's always something more to learn. And so using this strategic questioning, you can probe their deeper understanding of a topic, and you can find those things that they need to learn about, even when the patient itself may just have something very bread and butter. I'm going to jump back and talk a little bit about learning theory. And so just to review kind of what we're talking about today is bedside teaching. It's considered one of the most effective methods to teach clinical and communication skills, but the frequency overall is decreasing. And this is resulting in a decline of some of the clinical skills in our trainees. If you don't have the opportunity to be supervised at the bedside being taught these specific skills, you won't be able to do those independently or to pass those on to your future trainees. And the World Health Organization actually recommends that training programs should increase the frequency of bedside teaching in their clinical curricula, recognizing the value of these. But this is really easier said than done. There's a lot of possible barriers to bedside teaching, and I want to talk about how we could encounter those barriers and how we can address those things. So I think the first obstacle in like any part of education, but in particular in bedside or on shift or clinical environment teaching, is just time constraints, right? There's always a pressure to see more patients. There's always an increased kind of need to be doing other tasks, whether that's doing your record keeping or the workload of faculty that have other requirements like research, non-clinical teaching, other things that are being asked of them. And so there's always a lot of pull in multiple directions, and it makes it difficult. The next obstacle that you can run into is patient interest and confidentiality. When we're teaching in the clinical environment, sometimes that teaching really is at the bedside, and we want to make sure that we're thinking about the concerns about patient comfort, privacy, and confidentiality. Making sure that we are not, using those educational sessions to violate any of our patients' trust in us. The next obstacle that we think about is the reduced effectiveness due to the lack of involvement of senior faculty. And so sometimes when senior faculty are conducting bedside teaching or ward rounds, it tends to be led by someone more junior or a registrar. And I know that in talking with Dr. Anand and preparing for this presentation, sometimes it can be a little bit of a hot potato of who's going to do the teaching today. And that tends to be the more junior folks. But it's really important. And so we need to make sure that it's not just something that more junior people are doing. Because the senior faculty and the senior members of the clinical team need to really be demonstrating that skill. Again, another obstacle can be a greater reliance on technology. And so if we have the ability to do diagnostics, to do lab tests, to do things that kind of give us answers about our patients without using as much of our history or physical examination skills, that can cause those skills to degrade over time. And so one example Dr. Anand came up with was the question of a patient with a right-sided pleural effusion. Now, if you see this in your clinic or on your wards or in your emergency department, it can be easy enough for you or for your trainee to order an X-ray or ultrasound and kind of move on without thinking critically about this. But this is an opportunity to use percussion or auscultation or other physical exam skills and do teaching about those skills at the bedside. And so even though we have the tools to sometimes do diagnostics rather than our detailed exam or history, we want to not automatically jump to doing the things that can give us those answers. And again, we think about appendicitis, where a CAT scan can give us a 98% reliable diagnosis. We still want to have those opportunities to examine our patients and to walk our trainees through the examination process and the decision-making process. So the technological advancements that are available should serve as adjuncts to bedside clinical skills. Another big obstacle that has come up over the past few years is the transition from COVID-19 and virtual learning. And so, I feel like at least in my experience with COVID, there was a widespread disruption of the teaching curriculum. And very suddenly, everyone was learning in the virtual environment. And Zoom and increased kind of online simulation and non-patient care areas became the predominant place for education to take place. And so we need to transition back to some of the in-person examination skills. And so again, we have these newer platforms that can be helpful to conduct meetings, lectures, things like that. But the increased reliance in the virtual space and increased comfort in the virtual space should not displace our teaching. This one really resonates with me in my clinical experience. I feel like every shift I'm on, there's a new physician assistant or a orienting new nurse or another medical student or a new resident or someone else on the team who needs to learn. And we really enjoy having those people on shift with us. And honestly, I find it to be one of the most gratifying things in my career in medical education is working with those learners and making an impact. But at the same time, every time the group grows one person bigger, the amount of space, the amount of time, the amount of discomfort and difficulty with creating on-shift learning increases. Next is the sometimes hostile environment. And so preparing for this lecture, Dr. Anand talked to me about the process of washing, which is something I had not heard of, but was basically, as he described it, kind of a way to ask questions or find out someone's medical knowledge in a way that makes them uncomfortable publicly. And so making people, publicly wrong in front of each other is going to further increase the discomfort in that clinical environment. And then the other thing is making sure that when teaching is happening, that we're doing it with a goal of not embarrassing the learner or not asking, very minutia type questions, but really core content. So in summary, some of the bedside barriers that we see in bedside teaching, and talking to Dr. Anand, some of the Ghana specific barriers were time, an increasing number of learners, transitioning to the virtual learning environment, the patient experience of bedside learning, the increasing availability and reliability or reliance on technology, and then an occasionally hostile environment for teaching that makes people nervous about bedside teaching in the future. And when we compare kind of these reflections that we've had on the Ghana environment of bedside teaching to studies that have been published looking broadly at clinical environments in many countries, many types of hospitals, a lot of these things say the same. So in this study, they asked several people or several different hospital groups what barriers they had in bedside teaching. And this was specifically the physical exam. And the big things they came up with were very similar. Time and other stressors pulling you away from spending more time at the bedside teaching, that patient pathology teaching mismatch, and then hospital and student culture making it difficult. And so with that brief introduction on what's difficult about this, we started out with the challenges and we're going to end with the solutions. I wanted to pause to see if anyone had any questions or wanted to clarify before we spend a little bit of time talking about adult learning theory and how we can apply this to our bedside teaching.
Nothing currently in the Q&A or chat, Carrie.
Okay.
And Dr. Simons is pointing out that there's a publication from the US about pimping, which is our equivalent term to what sounds like washing, and its impact on learners, that is available as a link in the webinar chat.
Definitely. Yeah, pimping is unfortunately named historical practice in the US of asking lots of questions to the to learners to try and figure out the ideal way to use it is to try and figure out what people's knowledge gaps on certain topics are and use repetitive questions to identify and pick out what to speak about on rounds that day. But what unfortunately sometimes happens is it turns into either a competitive or an embarrassing or an esoteric kind of asking about unnecessary minutia of topics rather than what it was originally intended to be, which is really the Socratic method of having a conversation, having questions and answers about a topic to deepen understanding about it. All right. With that, we will spend just a tiny bit of time on adult learning theory. And adult learning theory is something that we could spend a whole lot, we could spend a whole day, we could spend a whole week talking about it. But I really just want to introduce it as a concept that we think about while we're planning our bedside teaching. And so andragogy is that adult learning theory compared to pedagogy, which is how we think about young children and learners who are not adults. And so when we think about our bedside teaching that we're planning to do, we have to reflect and think, who are our learners? What experiences have they had? What are they bringing to the clinical environment in terms of their skills, their previous knowledge, and how they want to apply what they learned today? And that will really shape the way we approach bedside teaching. I think if you take one thing away from this lecture, it is customizing your teaching to what your learners really need. Because when we think about adult learners, there's 5 key facets or areas of what makes someone an adult learner rather than a child learner. And so if you asked a primary school teacher how they would teach something versus how a medical school faculty, it's going to look very different. And there's 5 key reasons. The first is recognizing the previous experience that our learners bring to the learning environment. I remember humbling myself one of the very first shifts I had at my current job when I tried to explain some study that showed which antibiotic was most appropriate for a type of infection. And the resident presented the plan to me and I said, oh, have you considered using levofloxacin instead? Because of this study or this finding that suggests it's more effective. And they were very polite about the whole thing. They let me finish what I thought was effective teaching that ended up not being effective. And then they said, yes, I was an author on that publication. And here's why it doesn't actually apply in this case. And it was very humbling, but it was also really helpful because it was a good reminder that a lot of our students, residents, fellows, all of our learners bring significant amounts of previous experience, either in medicine or in other careers and other experiences they've had. And so remembering that and customizing their learning to recognize the previous experience. The next is that adult learners, we should recognize, need to be intrinsically motivated. You know, if you were setting up a primary school curriculum, you might use a sticker chart or some other sort of external motivation to encourage good behavior, to make sure that they're really feeling excited about the things that we're doing in class. But that's just not going to fly with our adult learners. And even if they're not as motivated as we wish they were, right? All of this is best case scenario. Even if they're not as motivated as we wish they were, it's really difficult to extrinsically motivate adults. And so to use this, to apply this idea of intrinsic motivation, you need to think about what matters most to the learners, because that's where they will be motivated. This kind of leads into the the third idea around adult learning theory. And that is that adult learners are problem-centered. And what this means is they do not approach a learning experience saying, I need to learn the entirety of this, this content. They don't say, I need to learn cardiology. They say, I'm on shift right now and my patient's having a heart attack, and I need to know what are the 5 next steps of what to do to take care of them. What they're interested in learning is around what they're trying to achieve, especially in the clinical sense. And so focusing on that problem-centered learning and that patient or clinical scenario-centered learning is going to make things more effective. Next is readiness to learn. Our adult learners come to the learning experience, in the best of cases, ready to learn and don't need as much preparation or priming as younger learners. And so just keep that in mind when you're planning bedside teaching. And then lastly, kind of tying all of this together, adult learners really want to have input into their education. They want to be able to have a conversation with you about what would I like to, what would we ideally talk about on bedside rounds today? And that input into their education really incorporates the fact that they are bringing previous experience. They want to have that input because they're intrinsically motivated. They want to have that input because they're problem-centered and they're ready to learn. And so keeping these 5 pillars in mind, we can apply adult learning theory to some of our ways to be most successful in bedside teaching, and some of the ways that we can overcome the barriers that we discussed. I'm going to pause for a moment to see if anyone has any questions about the things that we've talked about so far before we talk about some practical ways forward. All right, well, while we're waiting here, just to keep us moving forward on time, I wanted to talk about what are the ways forward? What are the practical things that we can do to apply this adult learning theory and overcome these barriers? And so, Dr. Anand and I chatted for a while about specifically the Ghanaian kind of context and what he thought would be the best way to overcome these. And so the first thing that we had discussed was compulsory allocation of time for bedside teaching with detailed planning. And so this is a way to approach it where we schedule a specific amount of time in the day during rounds on shift. Some part of the day is a protected time, and it's planned ahead by either the faculty or a senior resident or whoever is responsible for the teaching. And the teaching methods should be patient-centered rather than just a theoretical discussion. So again, it's patient-centered because our adult learners want to learn based on what they've encountered in the clinical environment and what they need to know. And we should have realistic and gradual escalation of the skills by the students. We don't want to show up, give a brief talk, and then suddenly expect they have a complete improvement in their skills. We want to watch those incremental improvements. The next thing we discussed was ensuring patient comfort. And so remembering our basic etiquette and remembering to think about our patients during these bedside teachings. And so avoiding stopping in between to make phone calls or answer your pager, using indiscreet language, and using basic courtesies. So introductions to your patient, getting permission from the patients to do some bedside teaching, and then especially keeping these prerequisites in mind if any of the teaching involves sensitive exams. And if the patient would rather not be involved in the bedside teaching, we give them that opportunity to say no, thank you. And we can still talk about the case in a team area or in another area outside of the patient's room. But often, if you use this etiquette and if you introduce the idea of teaching, patients are happy to be involved in the process. And it can actually really help them understand what's going on with their clinical care. If you discuss antibiotic selection with your whole team in front of someone with pneumonia, they have a much better idea of where that decision making comes from and how you can apply that in the future. Next, we recommend a focused approach by the teacher and student. And so really making sure that we're focusing on the goals of what we're teaching and avoiding tangential discussions. I know that sometimes, especially if we get onto a topic that is particularly interesting to us or something that we like talking about, there's a tendency to go on tangents and talk more than we should about something. But strategizing ahead of time and writing some brief objectives can help prevent these unnecessary detours. Next, we want to think about the integration of case-based learning. So case-based learning is a way of approaching learning that uses clinical cases and follow-up questions or follow-up evaluation or discussion to help students learn particular information applied to a clinical scenario, rather than presenting the information as just the following antibiotics are used for pneumonia, but using a clinical scenario to help teach those applications. And so what are the practical pearls? What can we do in the clinical environment? And what tips do we have to help faculty gain confidence to move their teaching from the corridors and conference rooms to the patient's bedside, to the actual clinical environment? The first one is preparation. So preparation is key to conducting effective rounds and increasing teacher comfort at the bedside. Trainers need to familiarize themselves with the clinical curriculum. And so you want to know what are the goals of the current rotation that your residents or your students are on. You want to investigate the knowledge and skills of your learners. You want to learn what are their knowledge gaps? What do they need to know about this topic that they don't know yet, so that you can customize their learning. And then lastly, teachers need to improve on their own history taking, examination, and clinical problem skills through the resources that are available to them. The next pearl is to draw a roadmap of what you plan to achieve at the bedside for each encounter. So ahead of time, you look at your patient list for the day, or you look at the plan for the day, and you decide what system is to be taught at the bedside. What specific aspects are going to be emphasized, whether it's part of taking the history, counseling the patient, physical examination, and choose just some of those at the beginning so that you don't go into your shift with this zeal for bedside teaching and then have rounds run 2 hours late because you tried to do too much. Sometimes it's helpful to have a theme for the day. So the theme for the day could be physical exam findings. The theme for the day could be kind of counseling patients, or kind of just within one of those categories, so that we don't try to do everything all at once. And then plan ahead of time, looking at your list of patients or looking at your clinic schedule for the day, and decide how much time is to be spent with each patient, keeping in mind which ones may be really good teaching examples. You want to orient your learners to your plans for the session. And so tell them what's going to be taught, and tell them ahead of time, hey, I'm trying a new thing. We're going to add some additional teaching during this session, and it's going to look like this, so that your learners aren't surprised or aren't taken aback by the fact that they're having different routines than they're used to. If you set those expectations early and you assign roles to each of the team members, this can prevent some of the confusion and chaos that can happen when you suddenly change the routine that everyone's very used to. And then really importantly, you want to establish some team ground rules. And so make sure that sensitive discussions are done in an appropriate place with the appropriate kind of sensitivity. So pearl number 4 is establishing rapport with your patient and getting patient involvement and buy-in. And so ideally, in this case, you've looked at your list for the day, you've picked your handful of patients that may have educational exam findings, and you've planned out your time for how you're going to teach at the bedside. Next, you're going to introduce yourself and the team to the patient and emphasize that this is a teaching encounter. You're going to tell patients that this is teaching because otherwise they may misinterpret kind of what you're doing. They may say, someone already examined me today, or they may wonder why you're repeating yourself, and it may actually decrease their confidence in you if they don't realize that it's for a teaching purpose. And so if you've introduced yourself and told them, we're going to repeat these parts of your physical exam for teaching, and then talk about your disease or your pathology or your treatment, then they understand what's going on and they can be more involved. And then pearl number 5, you really want to role model the physician-patient interaction. And so when you have these opportunities, you want to be the very best self. You want to think about how you want to reflect professionally and really model your interactions with the patient as to how you would like your learners to interact with patients in the future. And so we want to keep in mind that our learners are taking in all sorts of information during teaching sessions. They're looking at what you're seeing and doing and saying, and they're learning that knowledge, but they're also learning how to act. And they're also seeing you as a role model. So remembering this and bringing your best, most professional self to this interaction is really important. On the contrary, pearl number 6, sometimes you need to step out of the limelight and let someone else run the show, so to speak. Sometimes you'll have a senior resident or someone else actually being the one who introduces the patient, talks about the teaching, does the teaching with the residents. And this gives you the opportunity to step back and use observation to learn about your residents' clinical skills and also learn about their teaching skills. If you have a great senior resident who's able to both run rounds clinically and then take a step back and teach their junior residents and their students about physical exam findings, then you have a really great idea about how ready to graduate, how ready for academic or community practice that senior resident is. And so even though we have all of these approaches to how to lead teaching, also don't be afraid to take a step back and let others lead teaching while you do observations of how effective they are. So next, we want to think about how to create a conducive learning environment. We want our learners to look forward to bedside teaching sessions and not be nervous about them because they're worried they'll be humiliated. They're worried that they won't know the answer to questions. And so when someone says we're doing teaching shifts or teaching rounds today, the response should be excitement and engagement and not anxiety or fear. And so the questions that we ask our learners should not be these impossible read my mind type questions. They should be core content, and they should be going in they should be addressed in a way where more junior learners have the opportunity to answer a question on their own, as opposed to asking a senior learner and they don't get the answer right and then asking someone more junior. Because if someone senior doesn't know the answer, the odds that someone junior to them knows it on their own is low. And we don't want to create environments where people feel humiliated or uncomfortable. We want this to be a positive experience. And then again, keeping in mind our adult learning theory, keeping in mind all of the prior experience and all the enthusiasm that our trainees can bring to these sessions, you want to emphasize that you are willing to learn from the trainees as well as the patients. And so this can be a discussion rather than just a didactic, you telling them information and them learning. It's going to be bi-directional learning in both ways. And then pearl number 8, this is so, so important. Tell the learners what they have been taught. I don't know if this is as common an experience in Ghana as it is in the US, but I feel like I always have the experience of I've had a shift. I did a lot of teaching. I did a lot of redirection of resident plans. To myself, I'm thinking that was really great. And then I get my evaluation back from that resident, or I hear them talking to someone else and they'll say, yeah, the shift was fine, but they didn't do any teaching. And I'd say, we didn't do any teaching. I just did 8 straight hours of teaching. How is it possible that we didn't do any teaching? And it's because unless you specifically remind your learners that they're being taught with either signposting that says timeout, we're doing capital T teaching right now, or reviewing with them both ahead of time and afterwards that we just did teaching and here's what we discussed, they may not realize and they may not retain information as well. And so provide that summary, that post-teaching summary to your learners so that they can know and they can remember what was done. And then plan your time adequately. Make sure you're leaving time for discussions, questions, clarifications, because this is sometimes where the best learning takes place, is having a discussion amongst the team about, okay, now we start out with the core content about this topic, but then if we have the opportunity to talk about what are exceptions to the rule, or when have you seen this, when have you found this type of patient really challenging, that can be the meat of the teaching. And so making sure that you aren't running out of time so that you don't get to have these discussions. And then pearl number 10, you want to obtain feedback. After each bedside teaching encounter, there needs to be time for feedback from your learners so that you can find out what was their impression. How effective did they find the session? Was it on something that they thought was clinically relevant or important? But at the same time, it doesn't need to be a long sit-down debrief. It should be a brief session and not a prolonged, tortuous session of getting feedback from your learners. And then trainer evaluation and reflection is really important because you want to evaluate yourself and reflect on yourself and your experience teaching and how effective it was. Thinking about what went well, what went poorly, and how you would do things differently next time. This way, each time you attempt to add slightly more bedside teaching to your rounds or to your clinical shift, it gets a little bit better and a little more effective each time. And then again, we use that information, those reflections, to plan for the next encounter. And so I'm going to pause briefly, and our very last part of this talk is just a bedside teaching toolkit, some really concrete tips to overcome some of these barriers. All right, so tips for overcoming these persistent barriers. So all of this was I think, a hypothetical discussion, and I really appreciate you guys being willing to think hard about these barriers that we have to teaching, about how we can apply adult learning to teaching. But now soon, tomorrow, the next day, you're going to be on shift and you're going to be on rounds and you're going to have to know how to apply some of these. So what are some really concrete tips we can recommend? The first thing is setting expectations and planning ahead. So sitting down and looking at your schedule and saying, what is the next time I'm working clinically and how I can incorporate one small piece of bedside teaching, applying some of these principles. Before teaching, I plan ahead in a couple of ways. The first is that I look at the schedule and I actually look at the resident schedule to try and figure out who I'm working with and what experiences they're bringing into that shift. What year of training are they? Are they working on any particular skills? Are there procedures that they need more experience in? So I can keep that in mind, who is on my team while I plan. You always want to start small. You can always increase the teaching that you do if you're successful, but you don't want to start your enthusiasm for bedside teaching, try to do a teaching session on every single patient, and then rounds runs 2 hours late and everybody's cranky because no one's had lunch. And then I give myself a little pep talk before a teaching episode, and I try to approach it with a positive attitude. Patient confidentiality and interest is really important to keep in mind, but you want to remember the bedside teaching triad. And that is that bedside teaching can be beneficial to patients and families, as well as to teachers and to students. And so remembering to introduce yourself to your patient, explain that you'd like to do some teaching, give them the opportunity to say no thank you and to opt out, and have a backup plan for what teaching you might do and where you might do it if the patient respectfully says no thank you. But also keeping in mind that patients will often benefit from bedside teaching because after that, they'll have a deeper understanding of their disease process and of all of the thought and care that goes into their patient care plan. There's a couple specific bedside teaching advantages, but I like to think of them not as only bedside, but as on-shift teaching advantages, or on rounds, or clinical environment teaching advantages, because again, it does not have to be at the bedside to be effective teaching in the clinical environment. And so a couple of specific things that I will do, or that I will see others do, that's been really effective, is installing a small whiteboard or a chalkboard, or even just an area to tape up or put thumbtacks up with pieces of paper. But having a dedicated teaching area in the clinical environment can allow those quick 60-second timeouts to have some visual input as well, whether you're drawing a treatment decision tree, or you're explaining anatomy and you're doing a very rough drawing of the gallbladder or something like that. Having a space in your environment, such as a whiteboard or a chalkboard or even just some paper, allows you to create a visual reminder of the teaching that you did, so that for the rest of that shift or the rest of that day, people walk by and see that and have a small reminder of what you talked about that day. This also helps with that concept, going back, of signposting your teaching, so that the learners remember that we did do teaching today, and so that you don't get those evaluations that said, we didn't teach anything, because you know that you did. And if you use this tip, they can remember what happened. I'm going to jump ahead because we already talked about this with the first question. But another tip that I have is keeping resources on your phone that have either audio or visual or other types of input, so that you can compare and contrast with your patient. I have a patient confidentiality compliant, so anonymized, but I have a series of images that I keep in a Google Drive folder on my phone of abnormal EKGs, abnormal chest x-rays, and other kind of imaging findings or physical exam findings that I've encountered in practice, so that we can use them on shift to discuss. And so if we've got some downtime, I can simply just pull up an EKG and have the resident or have the learner talk through how they would respond to that EKG in real time. That can also be helpful when we're talking about that patient pathology mismatch, where maybe you see someone with chest pain and their workup is negative and they can be discharged home. There's often not as much teaching in that, but if you can pull up an x-ray that shows a tension pneumothorax and play the game of what if, and say, okay, imagine the x-ray had looked like this instead of the normal one that we found, what would be your next steps? And if you do this, you don't even have to do it very frequently. I'll add something to my clinical library of images, maybe once a week or so. But over the course of doing that for a few years, I now have a whole treasure trove of abnormal EKGs, imaging findings that can lead to some really effective teaching discussions, even if the patient pathology is relatively bland or not sick at all. The other thing that I'll sometimes use is just a simple Google image search. I do this all the time when I'm trying to teach about rashes. Again, trying to compare what the patient is presenting with and having a few pictures of, okay, how is that different from what we're going to talk about, which the teaching is herpes zoster in this case. So even though the patient in this example didn't have herpes zoster, they did have a chest wall rash. And we were able to review these pictures in real time and talk about why is it different from what we're seeing today, and how the treatment plan would be different. And so using those pictures and those other resources that you can pull up at the last moment or just on shift in a few seconds can help augment and increase the effectiveness of your teaching. And then one of the last things I'll talk about is, how do you keep track of your teaching? We talked about a whiteboard. You can use sticky notes, you can use a chalkboard, or you can use just simply pieces of paper that you pin to the wall or you tape to the wall to say, this is what we talked about today. But another thing that I found to be helpful is a shared Google document that you can share with the members of your team for rounds that day, or for that shift, or for that clinic day. And anybody can contribute to it on shift. But what you do is you just use a picture, not necessarily of the patient, but something you found on Google, or just one single lines like we have at the bottom here about someone who had pyuria and ended up having appendicitis. That way, at the end of the day, or at the end of the shift, or at the end of rounds, everybody can reflect on what was discussed that day. They can ask any follow-up questions. And again, that helps solidify the learning, because they have additional exposure to what was talked about an hour or 8 hours ago. And it helps get over that lack of teaching phenomenon where people say, oh, we didn't do any teaching today. If you have a Google Doc like this, you can go at the end of rounds and you can say, look at these 8 things that we talked about. And so I found this to be really helpful, especially when you've got a large team of learners. And this is something that you can even assign a member of the team to take some notes on what we're talking about, and you can check their learning while they're doing this. The last thing I want to talk about is just straightforward image review and board exam review. And so if you have a little bit more downtime, maybe you're waiting for a new patient or you're waiting for results and you have a few minutes, this is when it really helps to have resources like a textbook or an EKG reference book or flashcards of patient pictures, so that you can use those to spark discussion. Now, these are not necessarily related to the patients that you're seeing in the clinical environment right then, but it's a good way to take advantage of the brief downtime that you can sometimes get clinically. And it's a good opportunity to broaden your learner's knowledge, even on a day where maybe everything is pretty bread and butter and doesn't feel that educational. And so these are some of the tools I use on shift. We have an EKG reference book, we have a emergency medicine oral board review book, and then an Atlas of Emergency Medicine flashcard book. And all of these are just prompts to stimulate discussion so we can do some teaching, and so I can figure out where are the knowledge gaps, what else do I need to talk about. And so for your specialty, for your learners, you want to think about what are some resources I can just have with me on shift or in rounds or in clinic, so I can take advantages of those brief periods of time. So in summary, that was a lot of information, but what we're hoping you guys can take home from this is a reflection that yes, it is really difficult to do effective teaching in the learning environment. There are a lot of barriers, there's a lot of competing efforts for your time, but this is really important and valuable. So overcoming those barriers is important. I hope that you guys have had a little bit of time to think about adult learning theory and how to plan teaching around what makes our learners adults and what is important to them. And then hopefully our toolkit has inspired a couple ideas of simple, straightforward ways to incorporate even a small amount of teaching on your next shift or your next clinic day or your next day in the operating room. And so with that, I just want to encourage that teaching can sometimes be really hard. It may not go completely the way that you're hoping it does, but if you approach with a positive attitude and you're willing to continue to get feedback and continue to try new things, you will be really successful. And so with that, I will yield the floor to any questions or comments or discussions.
Thank you so much for that presentation. There are actually several questions in the chat, which I'd like to draw everyone's attention to. There are several people who are wondering about how to customize this to the larger groups and maintain learner engagement, particularly when there's a large group of multi-leveled learners at the bedside.
Yeah, that is a really good question. And I think that is the hardest, like in my experience, that is one of the hardest things to do, is take a group that includes like a first-year med student, a senior medical student, a senior resident, maybe a fellow, and somehow come up with something that's going to be educational for all of them. When I'm in that situation, there's a couple of things I recommend. The first thing is picking what learners I think are the most important to target in that group, and thinking about who you want to be your focus. And so for me, if it's a really big group, I kind of pick the middle and say, okay, I want my teaching to be really focused on maybe my mid-level emergency medicine residents, but I still want to have a basic enough introduction that the medical students aren't completely lost in what we're talking about. And I want to follow up, I want to have a few kind of next level questions or discussion points for my senior residents who maybe have heard me give this talk about hyperkalemia so many times that they could probably give it themselves. And so I structure a bedside teaching as maybe 20% basic introduction that is going to be valuable to everybody, and also just prime them to remind them what we're talking about. Review the anatomy or the physiology of the very basics. That way it's helpful for really everybody, but helps those junior learners get up to speed with what we're talking about. The bulk of the conversation will be aimed towards the middle of that group in terms of addressing their knowledge content. And then I try to have 20% at the end be that next level content that is going to pique the knowledge of even, an experienced attending who maybe hasn't thought about the topic in a while. But that is a really challenging question, and one of the things that can make clinical teaching the most difficult. Another approach to this is
Actually,
to engage in
Carrie,
peers.
if you can stop sharing, I'll put up an evaluation link while you're talking as well.
Yeah. So another approach for this is to do some peer teaching. And so if you can close that gap slightly by maybe coaching your more senior learners on how to give the teaching themselves, that way they can actually develop their skills, not just in content, but develop their skills in teaching as well. That way you've made the learner group just that much slightly smaller. But that is a really good question, and one of the things that makes bedside teaching so difficult.
There's a related question about whether these large group rounds and presumably very busy long rounds are the best place for bedside teaching, and how do we navigate a little bit I suspect the demands of time versus desire to educate and develop.
Yeah, I think that the bigger the group and the bigger your clinical to-do list, the more you really need to pick bite-sized learning opportunities. And so I think of a graph of like the larger your group is, the shorter your sessions are going to be, and the more complex your day is, the briefer your sessions are going to be. But it can still be really easy to get effective teaching in 30 to 60 seconds if you just play that game of what if. The other thing that you can do with a large group is try to have folks split up and kind of talk amongst themselves. Or you can split up the group and say, I'm going to take half of the team and we're going to repeat the physical exam on this patient right here, and give the other group, something to work on. You can go do your notes. That really helps people appreciate their time and that you're not monopolizing, like holding them hostage teaching for an hour, and gives you a little bit of time to spend with a smaller group so that they can answer questions.
And there's a strategy called educational prescriptions posted in the chat that we would love your reflections on. And this has to do with giving learners actual assignments to bring back on the next day.
And then I do see a comment about kind of segmenting the bedside, segmenting people versus a large group. I think it also depends, all of this is going to be customized to your environment. And so you are going to know which are those really crowded areas in the hallways of the hospital or patient rooms where you have all the best intentions to do some teaching, but it's just not feasible. And so thinking about these principles and adapting them and making them specific to your learning environment, it requires a lot of creativity. It requires a lot of dedication to teaching and not giving up on it, because it can be really difficult. But when done right and when done successfully, it's really impactful and creates for the learning that your students and your residents are going to retain for a much longer period of time. But I totally agree, it can be really difficult.
And Carrie, this question about this educational prescription idea that sounds like it's coming out of Duke, about giving learners some responsibility for the bedside teaching with assigned tasks.
Awesome. Any other questions?
Dr. Commissaris,
Yeah.
I want to throw this up there. In about 4 or 5 years now, most of our public hospitals have started using electronic medical records.
Mm-hmm.
And my observation is that sometimes when you are on ward rounds, not everybody is fully aware of the cases you are dealing with. I know in US, you may have pre-ward rounds engagement in a private room before coming to meet the patient. So you have an audience around the bedside where knowledge of the case you are dealing with vary. What would you suggest as a way of students, learners having better knowledge throughout to their world rounds for engagement? Thank you.
That is a really good question. I think that I've definitely experienced that. Like I don't do a lot of rounds anymore, but thinking back to my rotations and residency on rounds, it's really hard to keep the attention of the entire team. And you can certainly see where folks, if it's not their patient primarily, maybe they're on the computer or trying to do some other tasks for patient care. And then what I'm imagining that you're asking about is then you go in to teach about that patient and they really haven't been paying attention to what's going on with that patient and you lose some of that educational benefit. I think one of the most important things to do for that is to maintain a positive teaching environment and give a brief summary or have one of the learners give a brief summary of that patient before you jump into the learning. That's my recommendation for a very kind of realism approach of, you know, learners have so much they're expected to do. And so if they're trying to do other things on the computer and maybe have missed some details about the patient, we should give them the opportunity to get caught up to speed before we go into the patient's room to teach about them. Thinking back to some of our pearls about kind of planning ahead and looking at the list of patients for the day and deciding when and what to teach ahead of time, you can also give your learners that heads up and say, hey, Mrs. Smith or Mrs. Brown or whoever is going to be our teaching case for the day. And so even if this isn't your patient, like, please just take a quick look at her hospital course and get caught up to speed on her, because as a whole group, we're going to spend 5 extra minutes just discussing her exam findings. So you give people the opportunity to get caught up to speed, because I think if you try to jump right in without that warning, you will absolutely have some learners who don't get the correct context.
It sounds great. Thank you very much.
Hey, in interests of keeping us on schedule and respecting everyone's evening after work time, we're going to take a 5-minute break before the next session and reconvene at 25 past the hour with a session on how to design the most effective slides for classroom-based teaching. So thank you for everyone's interest, and we will be back in about 5 minutes. Okay, as everyone starts to regroup after that outstanding first session, we are going to spend the remainder of today's sessions talking a bit about teaching in the classroom environment and how to best design slides or graphic images to engage our audience and communicate our teaching points to our learners most effectively. And I will again turn this session back over to Dr. Comissaris, as well as Dr. Kwao from Kurlebu Teaching Hospital in Accra.
Okay, so good evening, everyone. And by way of introduction, my name is Dr. Nanasewa Kwao. I'm an emergency physician and senior resident at the Accident and Emergency Center, Kurlebu Teaching Hospital. And Dr. Comissaris will be my co-presenter on this presentation. A second presentation would be on best practices in slide design. All right, so our objectives would be to reflect on previous experiences and lecture for presentation. So want to have some examples of good presentations and bad ones. And then we'll review the cognitive load theory as it applies to multimedia learning and slide design. And then lastly, we'll look at practical approach to slide design. We're looking at text, font, images, colors, interaction, and some storyboarding. Okay. So, death by PowerPoint. Can anyone provide an instance or example of a dull or boring presentation they sat through? And what made a presentation boring or dull? I guess they can put the comments in the chats box. I don't know if my panelists have any example they would like to share of any. I'm sure we always will remember the worst presentation.
So we see coming in too long. And I think probably along with that, all of us would be remember those slides with incredibly lots of detail with very small font size or figures that we can't read, slides that are too busy, No pictures, no images. Boy, your topic is resonating with your audience.
Yes, yes, I can see in the chat, but yes, too long, loaded slides, no pictures, so everything is so abstract, you can't, and then presenters, of course, reading from the slides, word to word. Okay, so we'll move on to cognitive load theory. Dr. Commissaris.
All right, thank you for that introduction. So before we jump into kind of what are the practical ways to approach this, I wanted to build a little bit of background on the idea of cognitive load theory. And again, this is something that learning scientists and psychologists will spend an entire career on, and we're going to spend approximately 3 minutes on it. So this is a very brief introduction, but it's the idea that learning new information requires a certain amount of work, cognitive work of our learners. And what we want to do is to decrease the amount of work or the amount of cognitive load it takes for our learners to incorporate new information into the existing schema of their long-term memory of how they understand something and what they know. So I always think of new knowledge as kind of things that I'm filing in the file cabinet of somebody's long-term memory. And so what can I do to make sure that the things that they're filing away after a presentation or after any sort of teaching are actually what I want them to have spent that valuable cognitive energy on and are effectively staying in place in the files and the approximate places they need to be. And so to jump backwards just a little bit, I want to talk about the very basics of like, what is a presentation or what is a lecture? Ultimately, it's a multimedia presentation. And what this means is there's different types of media. There's words and pictures. And the words and pictures from any presentation, from any teaching, are incorporated into what's called our sensory memory via the ears and the eyes, right? This is the very basic, like, how do we intake sensory information? Well, first it goes into our ears and our eyes. And then our working memory will take those sounds and images and convert them into a verbal model and a pictorial model of what is the actual content that we're talking about, making meaning from the images that they're seeing, the words that they're either reading or the words that they're hearing, and organizing this in their working memory, in that short-term memory, and then eventually organizing that with the prior knowledge that's stored in the long-term memory, taking that little nugget of what you've been trying to talk about and what you're trying to teach them and putting that away in that file cabinet. And this can actually be really hard. And so the cognitive load theory is a way of approaching the external stressors, the things that make learning difficult. And there's 3 basic facets of cognitive load. First is the intrinsic load, or the inherent complexity of a task. It is simpler to teach someone that 2 + 2 = 4 than it is to teach them calculus. But at the same time, the complexity of something that we're trying to teach can be somewhat impacted if we try to isolate small pieces of information or better organize complex information in ways that make sense. The next kind of part of cognitive load is that extraneous load. And that is the manner of presentation or the environment of presentation or the environment of learning that that your learner is experiencing. And so when I think about extraneous cognitive load, I think about trying to do bedside teaching in the emergency department on a busy day. Your phone is ringing, the pager is going off, there's an overhead announcement, the nurse has a question, the other patient has a question, and there are all of these external, extraneous, additional cognitive load that makes it difficult for your learner to input new information. Similar things can happen in a presentation if there's lots of excessive non-educational visual prompts, distracting animations, other things that are not adding to learning but distracting from learning can create additional extraneous load. And then lastly, the germane load is the idea of the organization of the working and long-term memory. These are those file cabinets we think about when we teach someone about, a myocardial infarction. We want to make sure that they're filing that away in the right kind of organization system in their long-term memory so that they're able to actually incorporate that into their functional knowledge base and it becomes long-term usable information. And so that's the really basic idea of cognitive load theory. As we go through some of the practical approaches to how to design a presentation and what decisions you can make around that, I want you to keep in mind that what our goal is to address the intrinsic, extraneous, and germane cognitive load to decrease the amount of mental work it takes for our learners to create new memories and new knowledge. And so one way that this has been approached is called the Mayer's multimedia principles. These are a set of principles regarding teaching with media, so teaching with audio, video, visuals, that optimize the cognitive load to increase teaching. There are about 20 of these at this point. If it's something you're interested in, you can take a really deep dive into this information, but I'm going to talk just about 5 of them today. The first is the multimedia principle, and that is simply the idea that narration associated with pictures or other visual input is more effective at teaching than narration alone. And so this is why it's always really helpful to remember that a lecture with visual input is more valuable than a podcast. And now that's not to say that you can't learn things on audio alone. I love podcasts, and I think that like listening to them on my commute is one of the ways I've really expanded my knowledge base. But at the same time, there is value in those pictures. And so remembering that there actually is some learning value in including that visual input. Remember, we're using both the eyes and the ears. And so an example of this is, what is a square? If we had no way to give someone visual input on how to know what a square is, we could probably eventually get to that description. We would describe sides and angles and have all of these words that we need to use to describe it. Or we can just put up this visual input, and pretty soon our learners have a sense that there's 4 sides, they're all the same length, and all the angles are 90 degrees. Having that visual input increases both the knowledge retention and the ease of understanding. Another great example was a tweet that the New England Aquarium sent out that I found really illustrated the power of visual learning and the power of visual input. And that is, grammatically, what is the difference between fish as a plural, and fishes as a plural? And without nearly any words, they're able to explain the difference between plural fish and fishes because of the power and the efficiency of really good visual input. Next is the coherence principle. This one is fairly straightforward. It's the idea that people learn better when extraneous words, sounds, and pictures are excluded. And so anytime you're designing a slide, trimming the fat. And so this is our bad example here. Really, with the coherent principle, we want to exclude extraneous extra things. And so logos that are not required or not necessarily adding information, but maybe they're just part of our slide template, don't have to be used unless it's specifically told to you that they need to be used. Additional pictures of unrelated things or really busy slides with multiple pictures will not enhance learning. It will distract your learners and make them think about something else rather than the content you want them to be spending their energy on. So for example, if you're trying to teach about the X-ray findings of a pneumothorax, there are a couple of things wrong with this slide. One, you don't really need to have a title of this type of slide of reading a chest X-ray, because your learners presumably know what a chest X-ray is, right? If it's a type of study, if there's something unique about it, sure, you can put a label on that image. But if it's a chest X-ray, it looks like a chest X-ray, your learners are residents, they know what a chest X-ray is, you can get rid of the labels. You have a lot of text here that can be instead simply narrated. And then one of the most important things here, the tension pneumothorax, the label is actually obscuring some of the pathologic findings. And so instead, I would simply project the most valuable visual input to your learners, and that is all of these X-ray findings. And everything else can be narrated with a few reminders at the end to make sure that they know what they're looking for. Next is the signaling principle. This is the idea that people learn better when cues are highlighting the essential material. And so we're going to go back to our slide of a chest X-ray. During this presentation, we will have narrated kind of what is the approach to a chest X-ray. We will have narrated what are the abnormal findings, but to make sure that our learners are kind of looking at the right things, they're making eye contact with the abnormal findings in the EKG, we can use really simple cues that don't distract, but highlight the abnormal findings and make sure that we're having our learners look at the images in a way we want them to. So in this case, we have a shifted mediastinum, a collapsed lung, and increased rib spaces. But notice how we do this with as few words as possible, because if we have additional unnecessary words, that can be distracting. Next is the segmenting principle. I always think of this principle as the pineapple challenge. This was like several years old now, but there was previously a YouTube challenge where someone was challenged and took a video of themselves eating a pineapple with no utensils, not cutting it up at all, just eat the whole fruit and see how it goes. And it never goes well, because that's not how you should eat a pineapple. With the segmenting principle, the idea is you want to take this really difficult to digest, difficult to eat topic and turn it into nice pineapple chunks for your learners. So the segmenting principle is that people learn better from a multimedia presentation that is in small segments rather than a giant continuous unit. And every topic has chunks. And honestly, I think that the most important job of an educator is to think really hard about the topic you're trying to teach and figure out what are those small digestible chunks or segments that I can put this learning into to help make sure that it's effective. So those are just a few of the multimedia principles. And again, the idea is to make design choices that optimize cognitive load when teaching with media. So keeping those in mind, we're going to talk about some nuts and bolts, some really practical design tips that with minimal effort you can incorporate into your next presentation to decrease the cognitive load and increase learning. The first is talking about fonts, and I cross out that S because ideally you'll have one font in your presentation. There are certainly exceptions to this rule, but in general, to avoid increasing visual distractions, I would pick one font and stick with it. Now, jumping back in time to kind of the invention of written text, there's this idea of serif versus sans serif fonts. And serif really just means this little foot here at the bottom of this font. And this dates back to like Roman carving of Latin language. And the exact origin is unclear, but what serifs are really good at is keeping a solid baseline, and they can be really helpful if you're reading something dense, like a newspaper or a journal article. And you want to make sure that your eyes aren't accidentally jumping up or down a line while you're trying to read something that's quite dense. Sans serif fonts, on the other hand, do not have that little foot. And when you think about serif versus sans serif fonts, I want you to think about reading a map versus driving in real time. I think of reading something dense like a journal article or a textbook, similar to reading a map. You have time. If you kind of don't understand exactly what's going on, you can read and go back a few lines. You can clarify. You can look at a reference somewhere else. You can pause and not necessarily be moving forward at 90 miles an hour. If you're in a lecture, that's a lot more like driving on the highway. And that is the circumstance in which we use sans serif fonts because we want our text to have no barriers to interpretation and to be nice and crystal clear. Because the challenging thing about a lecture is if you don't know what's going on as a learner, it's a lot harder to take a time out and to reread or reference or ask questions or pause and turn back. And so because of that, we want our slides to look like, you know, those really clear signage and not those really confusing and detailed maps. Next is font size. Some people will tell you like hard and fast rules, like a presentation should have a 100-point font or 36-point font and should never be below this exact number font. And I just don't think that stands up in real life. And I think the reason that could be so difficult is because it's really going to depend on what venue you're presenting in and what amount of information you're trying to portray. Just as a few examples, whatever device you're on, wherever you are learning right now, this is an example of a 100 font, 64 size font, and even 36 size font. And already even our 36 is starting to look a little bit small. But if we think about the venue that we're presenting in, this is my classroom at Harvard where I do most of my teaching. And I look at what 100, 64, and 36 size font looks like. And from the back of my classroom at Harvard, 36 is almost impossible to read. And so this is not to say that you can never use 36 size font or that you should use one exact size, but in general, bigger is better. But most importantly, you want to know your venue and preview your slides ahead of time to make sure that whatever distance your learners are, whatever amount of brightness that you have, or whatever devices your learners are using, that it's legible to them. And so next we're going to talk a little bit about text. I'll have my collaborator take over.
Thank you. So when it comes to text, so this is an introduction slide on shock, and it's supposed to focus on the definition and effects. Now, the learner has to decide whether he or she is reading line by line or listening to the presenter. And I guess most of you are deciding to do that, whether to listen to me or probably read line by line what is on the slide. So it is very important that So it's very important that we use headings, major headings, and subheadings in our presentation. The subheadings and bullet points help to create a hierarchy within within your slide. So the major headings are usually bigger than the subheadings, and the subheadings are usually bigger than the regular font size. Bullet points or numbered lists help to break down the information into digestible chunks. So you know that we want to increase your Gmail load. So it's important that whatever you are trying to communicate to your learners, you have to break it down. Now, the use of highlights to highlight key concepts or key terms that you want to. So for example, in this definition of shock, I have highlighted a few key terms I want my learners to remember. So when they see the highlighted words, they're able to, keep these terms in their head. Now, you could see I've highlighted the last points. So the last text is a long sentence. I think it's more than 30 words. It's important that you are as concise and precise as possible, able to break it down. So this sentence, which states, when a patient presents with undifferentiated shock, it's important that the clinician immediately initiate therapy while rapidly identifying the etiology so that definitive therapy can be administered to reverse shock and prevent multi-organ function event. So this is a whole lot. You have to be as precise and concise. So reducing this to 2 simple sentences. In cases of undifferentiated shock, swift therapy initiation is crucial. Identifying the cause promptly allows for targeted treatment, preventing multiple organ failure and death. So it's important that, one, we use headings, major headings, and subheadings in our text, and then highlight key terms or concepts we want our learners to be able to take home. The next one I will look at is images, right? So the use of images. Sometimes you want to project your image so that learners understand what you want them to understand. So it's important to use high resolution images to maintain visual clarity and professionalism. So for example, your top left, the pixelated image is making it very difficult for your learners to read exactly what you want. And it's an example of an extraneous load. It's just there to distract them. It's also important to avoid overcrowding your slides with too many images. So on your top right, you can see that there's too many going on and your learners will be unable to decide which image they're supposed to keep in their head. You're supposed to maintain a consistent style and theme for your images. So for your bottom left, the image is too crowded and there's a lot of inconsistency with the visual image. With your bottom right, it's poor quality. You have to consider your colors because sometimes if the colors are too contrasting, it becomes difficult for your learners to be able to grasp what you want them to. So for the next slide, I want to illustrate something on team-based approach. So I just have one picture sort of showing a team meeting going on, and then the little text talking about team-based approach. So if your learner have this image in their mind, they're able to remember what exactly team-based approach is. Okay. All right, so the next thing we'll be looking at is color. It's important to establish a consistent color plate for your presentation, and this will promote some sort of cohesion during your presentation. You have to consider the psychological impacts of colors. So it said that if you decide to go with a color blue, for example, it conveys some sort of trust and professionalism. And if you use more of red, it's like more of importance. So you can see that you have to choose text colors that provide strong contrast. So you have to use a dark text on a light background or vice versa. Establish a consistent color palette during your presentation. So if you decide to go light blue or light gray, make sure that it's consistent throughout all your presentation slides. Avoid using too many colors, as this may be distracting. So you can see on your left, there are too many colors in the background. It makes it difficult for you to even read the text in the box. So sometimes having a plain background with just a few text colors will be able to visually convey whatever you want to for your learners. Okay, so that is for the color scheme. So how do we promote interactions during our presentations? So we'll just go through a few of this. So you can use polls and surveys in your presentation, right? And these ones can help to spark discussion, engage your learners' attention, and will be really interested in deciding, collecting information as to what polls or what the results are. You can also insert discussion prompts, so open-ended questions on your slides, right? And this will encourage your learners to share their thoughts or experiences related to the topic. We also talk about case studies. So you can also insert a relevant case study to your topic, and then ask your learners questions on diagnosis, on treatment, or decision making, just trying to invite their inputs into the discussion. You can also break your group into smaller groups for discussion, right? And give them a specific task related to the presentation content. And they will just discuss and then bring out some feedback at the end of the discussion. Also, you can also do real life scenarios. So ask residents how they would have managed this case if they were in a similar situation, all that. And it's just a way to prompt them and allow them to share their insights within the presentation. Also, peer teaching is very good, where you encourage your learners to teach one another a concept or something that you have taught. And then that way it reinforces learning. You can also have interactive elements in this age of where we are doing a lot of online presentations. So you can have some clickable diagrams and drag and drop activities or simulation within the presentation, just so that your learners can experience some real life scenarios. You can gamify the presentation, right, by turning it into a quiz or a game. And then residents can earn points and all that. And that will really encourage them to really contribute and get involved in the presentation. You can also use chat and discussion platforms alongside the presentation, allowing them to insert their thoughts or questions as the presentation goes on. And then role playing is where your learners can take up different roles or scenarios. It allows each learner to actively participate in the discussion as well. You can also have live demonstrations just to stimulate or illustrate some concepts. And then you can insert, old-fashioned short quizzes or knowledge check questions at the end of your presentation. And then, in the form of pre and post test questions, so that immediately after the presentation, you discuss them. And that is where you can also reinforce learning or the key points that you want your learners to take home.
All right, and in the interest of time, I'm going to jump ahead just to our last section about storyboarding and scope. So we've talked broadly about just what is the overlying theory that we're going to apply here of multimedia learning. We've talked about a couple concrete nuts and bolts of what are some basic decisions that you make when you're sitting down at PowerPoint or building your presentation on whatever software that you use. But in between, there's the really important step of storyboarding and scope. What's the content of what's actually in your lecture? And this is where I recommend that everybody choose 3 take-home points. And I sit down, and every time I try to do a lecture about a new lecture about a topic, I say, what are the 3 things that I want my learners to take away from this? And I really try to think about, what do my learners already know and what do they really need to know on this topic, and make sure that my 3 learning points sit in between those, lines of what they know and what they need to know. Everything else is extra. I can have as long as I want. I can have a really short talk. I can have a long talk. But fundamentally, I still think about 3 key ideas I want them to take home. Just because I understand the limitations of like the human working memory. It's really hard to take things away from a lecture setting. So then I've picked my 3 key ideas. I've kept my design principles in mind. And this is where I start doing storyboarding. And sometimes, especially if I'm doing a talk on a brand new topic that I haven't talked about before, I'll start with sticky notes on the wall, and I'll map out my lecture of what content do I want to cover? How do I want to section it out into different parts of the talk? What visual inputs do I want? Where do I want to incorporate example clinical images? Where do I want to incorporate some interaction? And how the sticky notes are really nice, because then you can move and rearrange until you feel like it makes sense. But then what you have to do is stop that process and ruthlessly edit, because again, you want to make sure that you are keeping a reasonable amount of learning goals and objectives. And you can also do that even within your presentation software. So on Google Drive, just in slide sorter mode, I keep a little section of slides at the end that are called trash, and maybe I'll resuscitate them later and put them back into my presentation if I realize that there may be time for them. But again, I'm ruthlessly editing to try and make sure that the content that I am giving is really related to what my learners need to know. The last thing that I will say about this is to know your timing and be realistic about your timing. It is always better to be invited back for another presentation, or to have eager follow-up questions about something that you maybe couldn't get into because of your limited time, than it is to go late, and especially to go late as the last talk before lunch. So again, knowing your timing, being realistic about your timing, and reflecting on those 3 learning points that you want your learners to take away, so that you really have a lecture that you're proud of and accomplishes your goals. And so to summarize very briefly, you want to keep text concise and simple, keep color choices harmonious, know your venue and know your audience, use clear and consistent fonts, and reduce cognitive load to increase learning. And so with that, we can answer any questions or any comments that folks might have on this topic.
Carrie, if you'll flip your screen sharing off, I will give everyone access to an evaluation QR code, as well as the one that I just dropped into the chat a couple of minutes ago. And I will also confess that I had some internet problems, so this is a universality regardless of where we are. So I don't know if I lost questions in the chat or the QA when I had to log back in. So if people have questions, please feel free to send them back along. Carrie, you've been doing this for a long time. What is your sense on how much time it actually takes to design a lecture using these principles?
That's a good question. I think it depends on a couple of things: how much you're really starting from scratch, and how well you already know your learners. I will confess that this talk in particular took, I think, a bit more time for me to prepare, because of just my lack of familiarity with the Ghanaian system, kind of what other experiences the college has had in education. And so I spent a lot more time researching and trying to understand my learners, and trying to kind of know what the best things to talk about would be, versus when I give a talk to my like intern residents, my core group, and I feel like I know those learners like the back of my hand, and I can pull learning points out of the sky for them. But as a rough ballpark, I feel like for a lecture, it's at least a couple of hours of front end effort. And I try to do that a couple weeks to months out, so I can put a lot of effort in it and then put it on the back burner and just let it marinate for a little bit. And during that marinating period, I am asking people questions about the topic. The residents can always tell when I'm working on a lecture because on shift, I'll start just quizzing them about what's your experience with managing this thing or that thing, or what questions you have about this topic, because I'm trying to pick their brain and get that information. So I would say a few hours of upfront effort, a few weeks of letting it sit on the back burner and marinate and getting questions, and then some last minute editing and kind of revising before the presentation. But the longer you practice these principles and the better you get at slide design, the faster it becomes easier to make a presentation each time.
Yeah, and I think something you said really resonates with me, that this is a dynamic process, that you have to keep going back to it and reflecting on how the presentation went, especially if you're giving it again and making refinement. And there's a very specific question that I think you can weigh in on, which is about font size and type, and what would be ideal from a teaching perspective.
Yeah, so I think the ideal font is something that is like clean, not distracting, and not difficult to read. So I use Arial for a lot of my presentations. Any sans serif standard font is fine. I think that there are circumstances where you can use a more interesting font if you're trying to make a specific impact, but for the most part, I use Arial, and I use somewhere between like 36 and 68 size font for most things. But again, it's really going to depend on what venue you're presenting in, because there are places, if everyone's on their phone and 6 inches from the screen, that 100 font can almost become overwhelmingly large if everyone's on a close screen, or if you're in a big auditorium with hundreds of seats, even that, 36 starts to look crazy small.
We are currently at 1 o'clock. This is a super fun topic. I know we have Dr. Komisaris present to our educators on at least a yearly basis, and she does such a wonderful job with it. And Dr. Kual, we really appreciate your engagement in this, and it's such a nice, smooth presentation transitioning between the two of you. So as way of promoting next week, we have sessions running from 1600 to 1900. So it's a little bit longer session than last time. And we're going to be covering some basics of simulation, and high-level overview of concepts around assessment and feedback, so that how do we evaluate our learners effectively, and also a session on feedback in the practical one-on-one conversation sense, and how can we utilize best practices to really get our learners to engage with performance improvement and development based on our own observations. So Dr. Lawson, any last words?
Just to say thank you for the audience for sticking with us. We started with lower numbers. It went very high, then it dropped again. But I hope that we'll get more, because we have over 250 participants registered. So I'm hoping the next session we'll get more. And please fill the forms, the feedback evaluation forms. It helps us sort things out to make life better for you. So thank you, Laura. Thank you, team, for this session. Over.
Thank you very much for the rich content you've given us today and the time, energy you put into all this. Thank you very much.
It is my very great pleasure.